Evening and welcome to this meeting of the Adult Social Care and Health Select Committee. I'm Councillor Lucy Knight, Chair of the committee, and I will be chairing tonight's meeting. The meeting is not going to be live streamed on YouTube, however, it is being recorded and will be available to watch back at a later date when members of the public and the media are welcome to watch the meeting remotely and listen to the discussions that took place. Now, I'd like to welcome you all to Committee Room 1 at Kensington Town Hall, and that before we proceed with the meeting, can everyone please make sure their mobiles are on silent or switched off, and we are going to start for 42 seconds silence to remember those who lost their lives in the Grand Lodge.
Thank you.
Thank you very much. Starting with apologies of absence, we've had apologies of absence from Councillor Stephanie Petit and Councillor Roberto Whedon-Sands. And I would assume Councillor Almond is probably on her way for work. Declarations of interest to any members having any interest in the care. The minutes held on the 6th of November will be submitted for confirmation and the next ordinary meeting of the Select Committee, just because of the time between this meeting and the last. And then moving on to agenda item 4, which is the budget proposals. This report is being presented to Adult Social Care and Health Committee as part of the budget working group scrutiny of the 2026-27 budget. This report provides the committee with budget savings and growth proposals for the services under the Adult Social Care and Public Health Services under the committee's remit. Also provided at page 29 of the agenda pack is a report outlining the director's budget and statutory and discretionary spend, which has been compared to support that committee in the budget scrutiny activity. Attending, we have Councillor Josh Rendell, our lead member, this Sivan, Director of Adult Social Care, Anna Raleigh, Director of Public Health, and Tom Dennerly, Finance Lead for Adult Social Care and Public Health.
And we also have Usman as Deputy Director for Public Health as well.
So I don't know who wants to lead.
Thank you. I can start the chair. Thank you. Thanks for inviting us here tonight. And I'm conscious it's been a big week with obviously the just referred to the fire in obviously Hong Kong that we all seen on TV. I think when you said, Chair, about the Grenfell 72-second silence, I think a lot of those images does trigger a lot of memories for a lot of people, especially it's quite similarly eerie. So just obviously thinking about everyone there, but also the cyber attack that the council has had the last few weeks, the last few days, and I'm conscious that's probably affected the live stream this evening. So working towards that, and I know the team are on it as well, but it has had day-to-day impact on some of the services that we're doing. Obviously, trying the best we can when we find out more information. So yeah, I'd like to present the draft budget for Adult Social Care to the Select Committee. As you've seen, it's a big budget day all around, not just for RBKC. But we've had to make a series of savings that we put forward as a proposal. We'd like to get obviously your help on this as well. This is for various reasons. Obviously, the most being that our £82 million funding cut we're getting for RBKC. Many central London boroughs are facing a huge funding cut as well over the next 3 years. But that means we need to start next year effectively to try and think about that. And as you see, we put forward a savings proposal of 3.5 million for this portfolio for this year, and potentially another 3.8 for the following year. Since I've been in this portfolio for 2 years now. We've had to make savings every single year, but this year has certainly been the toughest. Again, 40% of our entire spend is across the council is being cut. So we've had to make some really tough decisions I didn't want to make, or we didn't want to make, but we have to, just on the basis of where we are. So you'll see what we presented here this evening. It's not going to have a real impact on frontline services. That's the one thing we've been clear about. I've been clear about wanting to retain that as much as possible. But there are some behind the scenes things that we've had to really consider, and especially around contractual arrangements, staffing costs. We've had some voluntary redundancies that have been put forward as well, in order to kind of meet our targets for this year as well. However, this is not all doom and gloom. We do have some proposals, as I've said in previous meetings, for capital spend, and that's in the report as well. Future years, things like St Helens Gardens or the Kingdom House at the same time. But also we do have a 1.5 million growth pressure as well, which we've also put in the paper, and that's mainly due to increased increased people needing our social care assistance. So slightly different to our savings, but there's still societal pressures in order to do that at the same time. So yeah, that's what I was trying to say. Very, very difficult circumstances we're in. But I think we're getting there. But we've put across savings across ASC, and also Anne may like to speak as well on the public health savings, which we've also put forward. Again, public health is a grant, so it's not exactly savings, it's how we can use that money better, I would say, across council. But that will have an impact on day-to-day public health initiatives that we'll have to kind of relook at as well. You may have some questions on that. But yeah, really have to any questions, Jeff?
Anna, do you have anything to add?
No, I think Councillor covered, so happy to go straight into questions.
Thank you, and thank you for all coming today. And I appreciate what a job you have and what the amazing job you've done in previous years to balance the budget. So, well done. I don't know if anyone wants to start on this.
I can start. Thank you. I'd just like to know, the service saw a 12% increase in the service users last year, and I wanted to know how confident you are that 1.8 million demographic growth allocated is sufficient to meet the statutory need from 2026 to 2027. How confident are you?
So I can let this come under this, but also you're absolutely right. I asked this question myself
And
as well.
also,
Yes, of course.
There's another,
Yeah.
I've got another two. What assurance can you give residents that quality, choice and dignity will be maintained even on a tightened budget? And how are we working with NHS partners and BSCs and community network to maintain rising demand collectively and reduce long-term pressures? Those are my three questions.
If I can start, and this or other colleagues may be able to fill in the first detail. So Paul, you're absolutely right about the first question. I asked this myself, but I think we're pretty good at kind of tracking the need, but the transitional need for one thing, but also the need for people coming into the system. We do this every year. I think we're pretty good at nail on the head every single year in regards to the people that need to come in and get assistance from adult social care. But this year is bigger. So previous years we've had £500,000 put in for additional growth pressure. This year is much bigger because we are expecting a much bigger proportion of the population to come through and need adult social care needs. So it's gone from 500,000 to 1.5 million plus regarding the growth pressure. But I think we've kind of budgeted that, and then we've got that significant amount of support of people coming in at the same time. Biz, do you want to do that?
I think, thank you. Just to add a few points on the first question, is that yes, there is an increase in number of people coming to contact with us for settlement services. That has increased from 22, 23 was only about 2.5% increase in numbers. Last year we saw a huge increase, 12%. Unprecedented number of people came in. There are various reasons for that. It could be the health service was started doing all these elective surgeries and discharging people, clearing the waiting list agenda. So that probably created more people in need of reablement services and also assessments, etc. And then we think that it will go down, but however, the complexities in people's needs continue to increase, so that people live longer. That's good news, medical advancement, etc. But people also talking about living with frailty and need of more care and support. And also cost of care is also going up for various reasons. National insurance increased last year, and also difficulty in recruiting people. All these things are creating a pressure in the budget. We cannot simply base on OBR projection on wage or the inflation or just the Bank of England interest rates. It's also about the wage inflation is based on supply and demand of workers in the market. So if you don't have staff, they will demand more money. So it's driven by that. So all in all, increase in referrals, increase in complexity, fragile market, all creating this the budget pressures. Your second question, Roger, is about the insurance, how we're going to continue to provide the high quality service we want to provide. But you were involved with the CQC inspection preparation, and also you were interviewed by CQC as well. We got the report, and it was an outstanding, and at the time I was interviewed as well. And so we got and they told us that we're providing high quality service, and we are determined to continue to provide the high quality service. Of course, we need to be financially disciplined. That's what we have, all these innovative and creative ways to manage the tight budget or shrinking budget. Like Councillor Randall was saying about the 1.5 million, we need that, and we got that, so that will help us to, provide the right service for the right people at the right time. And I just want to, the final question on the NHS, working with the NHS, is, as you know, NHS is changing a lot. It's a big organization. Sometimes it's difficult to work with them, but we have a very good local partnership arrangements in place. And we make sure our residents get the right care from them. That's why you see in the savings proposal there is an NHS community care. We identify that as the savings. I would say that is something, if someone is entitled for services, they must provide. And we are here to support our residents to go through the process with the support of voluntary organizations, etc., to get that support what they need. So we will make sure people get the right support. We will do everything we can, but it is a difficult the market, and also it's a demand, and it's complex, isn't it? It's not just social care. It's not just social care. We provide care. We are impacted by the NHS, what they do in their care arrangements as well.
And can I just add on to the growth, and why do you think the 1.5 million is sufficient? We work with performance colleagues and adult social care to track the number of monthly starters and leavers in terms of care in our overall service user base. But last year was definitely an anomaly in terms of the trend data that we saw. That has reverted back to something similar to our 23-24 levels, slightly higher, but not significantly higher. And that's the basis on which we're projecting the growth. We are recognising the fact that we had a spike in service user numbers, and that's why the growth will be significantly higher. But we're confident that the trend has plateaued and come back down to kind of more usual levels, which is more consistent with the ONS data that we use to project and the trends moving forward.
Can I just ask a question on, you just said how can you be confident in that last year was an anomaly when?
Well, it's just the data this year has reverted back to a kind of level of month-on-month growth that is more consistent with prior years. So just the data that we've got from April through to now gives us that kind of level of assurance. Obviously, these are models and things can change, but we've got a degree of tolerance that we think is.
We saw this, because we are Alibaba as well, so we've seen the same trend last year, and this year is that trend is going downwards trend, but we can't come to a conclusion that is going to be the trend.
Yeah.
Because we haven't worked during the winter yet, so we don't know yet. But I think it is coming down.
Did you sort of foresee the 12% last year? Because it felt like that.
I think we knew that in the Q4 we saw the referrals numbers growing up. But we expected that because of the NHS speed up elected admissions.
Yeah. And then just on what you touched on in terms of workforce, which obviously I completely appreciate that we had an outstanding CPC report, which is great. Obviously, in order for CE to have fantastic outcomes, we need to start to be providing good assessments, safeguards reviews, delivering renewable, sort of what assurance can you give to the committee that even with workforce savings, we will not be sort of increasing caseloads or affecting safeguarding and the outcomes of our care, which I think Usha did touch on.
Yeah, I think the two things: the workforce is employed directly by us, social workers, and the workforce employed by our contractors agencies. I think we do quite a lot of work with the agencies to make sure that they are a strong workforce. We're helping them to grow and create that market where they can recruit people. In terms of social workers, you're right, Councillor, the CTC also recognised that we have one of the highest retention in London, also in the country, for staff, for social workers. And that hasn't happened immediately. We've been working on this for a long time, investing in learning and development, working with the universities, working with our learning and development teams, working with the local agencies, etc., bringing people and supporting them, etc. That helped us. The answer to your question is that workload in RBKC is about 23 cases. The average workload in London is about 25 to 30. So I'm not going to sit here and say we will be able to maintain that 22, 23 workload, but I think it will go up to maybe 25 something, which is very reasonable. I'm very confident that will not affect the quality of service we've been providing. But it's not just we have to find savings staffing, but those staffing savings are carefully thought through. They are, for example, if I give an example, but we have some social worker vacancies, and we want to recruit instead of social workers, we want to recruit social work care navigators. Because we're getting funding from ANA Service Public Health, and there's a lot of local resources. So these care navigators is able to identify and then connect with those provisions in the borough. So it's not, we didn't have any excess of social workers, but it's about managing within the budget. But like Councillor Handler was earlier saying, it's not acting on service delivery or reducing the disruption to service delivery, but maintaining the good quality service.
Outstanding services.
Outstanding service. Question on contingency, which is just quickly on in terms of the contingency funds that you received last year, which I think is why it may be in a much safer and more comfortable place this year. I just want to ask, can we sustain a balanced budget without contingency? And I guess sort of just talk to us a bit about.
Well, we have to have a balanced budget no matter what. Many of our services are statutory, but this portfolio provides, so we have to do it no matter what. Unlike other parts of the council, perhaps where it's a bit easier to look at services provided. So absolutely, I think it's going to be a challenge though. I'm not denying that. There's going to be some impact, especially if the fairer funding or unfairer funding, the Central London formula comes through. There's going to have to be really tough decisions at some point, not this year, potentially not next year, but when the following year, when the council has to save 50 million pounds, this year's only next year's 50 million, the 2 years 50 million pounds to save. That's going to have a massive impact. So I can't promise right now, yes, but I think that'd be a realistic way. Obviously, doing our best to maintain that. And I said the public health have tremendously with some of their grant with that so far, but it's yeah, I'm not going to sit here and say that everything's roses because it's not. But I have confidence that we'll try our very best to get where we are, basically.
Really, it's just slightly picking up on that. In that, one of the thing about adult social care is actually quite demand led, isn't it? So it's difficult to predict, and just what flexibility is in the budget for a really cold snap winter or something that actually is not predictable, or less predictable. So with a really tight budget where we've brought everything back.
I think this year is hard. I'll let this come in, but this year, for example, I think it's one of the first years that there's no extra provision for winter coverage, especially in the hospitals.
Yeah.
So usually, as you know, there's a grant from the NHS to the hospital trust to have a kind of a winter kind of a boost. That hasn't happened this year. So there could be a potential increase in discharge, delays of discharge, but even with the delays of discharge, people then who come out and then need our services outside of the hospital setting could increase again. That will have an impact, Gerard. But it's just really it's difficult. It's difficult.
And then tied up with the second question: are you getting any? I mean, every public body is trying to cut back and save money, and to some degree, palm off services that they would have done to other agencies or other organisations are also trying. Working with partners, do you get a sense of are we going to get any detrimental effect from cutbacks by other agencies, NHS, other agencies, that will put even more pressure on our budget?
Yeah, I think it's a good question. Actually, it's a sort of a direct and indirect impact, isn't it? That the NHS, their drive now is to clear the waiting list, so they're working on that. But at the same time, they're also cutting staff as well.
Yeah, and the issue is too, Gerard, that when we do with our commission services, they're asking money more from us because of the NICS rights. So we have to pay them to pay for that tax, which is really hard, and the council as a whole has to pay for the NICS rights too. So there's like £2 million taken out of the overall council budget that we're having to put to extra tax. So this is having an impact too, because our commission services, we can't afford to do the service unless you also give us a bit more. But we don't have to do it because there's always there's that kind of miscommunication, because I think people assume local authorities, government, whoever it is, has all this money and we don't. So it's very hard to balance these sometimes. And when we have gone out to providers, recommissioning of services, especially, we are obviously trying to save as much money as possible in those services too, because still provide the service, but maybe have it a bit more slimlined. Maybe not do something as nice as potentially as we wanted to.
So how do you square that circle when when there isn't a contingency? How do you square that circle, or do we come back 6 months into the financial year and say we're going to have to readjust everything?
I think the Q2 is forecasting a balanced budget. Yeah, but like you said, it's a demand-led budget. We don't know what's going to happen during the winter time. Flu and everything, as we've seen an increase in number of people admitted to the hospital, etc. So, but based on our analysis and numbers, etc., working very closely with the finance colleagues, Tom and his team, and our performance team, we still think as it is now, we'll be able to come balance the budget. but there's no guarantees in there because, like I said, it's a demand-led budget. And NHS, if they come up with another savings proposal for in 2 months' time, and that's going to have an impact.
In the
on
past,
us.
we've had flexibility in the budget, so
We have-
to cushion
Yeah,
that.
like the point is about 1.3 million. We had social care grant. Now we used all of them in the year. But that is in the forecast in the quarter two. That's what we are balanced.
Yeah, but it's a really fair question, and particularly for 26-27 budgeting, we've got a model that indicates what we think demand pressure is likely to be next year, and it's based on a set of assumptions that are reasonable and accurate now. When we get to 26-27, if there is a significant spike in something, demand goes up, then the basis on which we set out that model is therefore kind of inaccurate, and there is additional pressure according to the directorate. I mean, the director is excellent at being able to assimilate some of the information we're telling them and create mitigations and strategies to try and bring things in under budget, and they've been able to do that so far. I mean, it depends how big the spike is and how much early sight we have of it, but all we
And
can
improved
do-
monitoring, I guess. isn't it?
yeah, it's critical that we have accurate monitoring and we can share that information as quickly as possible.
I got a call with Tom on a weekly basis on a Friday. So that we know exactly, where we are heading and what are the risks, etc. But again, I must say it's a demand-led budget.
Mhm.
If there is a spike in demand in the winter time, then we probably going for an overspend. But I would say that we will do everything we can to make sure that good quality service at the same time I'm within the budget. And we've got a track record in delivering all the savings. And some of the savings, if necessary, then we need to work hard to get more excess, more than what the target is to balance. But it's not really very straightforward like other services or departments, the statutory service. And we have no choice. We have to work with the NHS. NHS operational changes or strategic changes will have an impact on us.
Thank you, Chair. Thank you for all your work on this. And I've been through it with you before,
Yeah.
so I know what a huge process this is. I have a few questions. Do we hear anything on fairer funding?
So the consultation for fairer funding, the government published their response last week on it. We don't have any figures yet, so we're not going to get those, I think, till the 23rd of December or October, really late December. I think 23rd of December we'll get our settlement. We don't know what that figure is yet. So we're still working the presumption that the worst case scenario, push the £82 million deficit, which I probably think it will be, just the basis of where things are up today, especially after the budget. And then we're working on that presumption for this budget, basically, the next year. We've taken all that to account.
And then my next question was about the underspends in the commission services. And I just thought that was an interesting comment that there's quite a few of these services that do underspend. And I just wondered why.
I think this is the commission, which
The commission services, 3.7.
okay.
Sorry, you should have Gareth.
Yes.
That is, I think that this is what Tom and I have been talking, is that all of these we need to sort of year on year we need to adjust the budget, which we will do it. I would say we need to see as a whole budget rather than each headlines. Isn't it, Tom, that we will need to sort of look at the budget allocation for each directorate based on the activities?
Yeah, absolutely. But in the commission services budgets contains a degree of contractual spend, and commissioners are working really hard to ensure that they can be as efficient.
Does it mean that we're just being very I mean, it's just interesting that maybe we're not being tough enough on them. We're like, why are they under? Maybe we're being too generous. I mean, I don't know what the exact mechanism is, but it just seemed interesting that there's so many, it's not huge amounts of money, but
Yeah.
it just seemed interesting that they were suspended.
So some of that variation relates to contracts starting later than anticipated. Some of it related to, particularly with health visiting, there was some work that was done to set an average for what the cost of the contract would be over 5 years. Once we identified that, we amended it immediately so it was against actuals. So we're not in a position of overspending or underspending. So again, that shifted into a very kind of small variation there. With regard to health workers, the budget was set before we were taking a decision on the future of health workers. So then we had a little small variation there. Throughout the course of the year, we're continually monitoring budgets, and when we do identify money where we think there is going to be an underspend or indeed an overspend, we're continually adjusting against those budgets. So that work takes place each month and then is reset each quarter with our finance colleagues. And then moving towards the end of the year, you'll recognise that in public health, we're actually working towards an overspend each year, and we're drawing down from our reserves. Now, the reason why we're doing that is not because we can't manage our budgets, it's because over a period of time, our reserves built up, particularly in the pandemic, when we were unable to invest in services that our inflationary uplifts were coming through. So that meant that our reserves built up. We've been asked by OHIMS to reduce our reserves to prudent amounts. So we've set a work programme and we've set a, if you like, a budget that in excess of the amount we received this year to enable us to reduce those reserves.
So actually, I'm glad you brought this onto public health, because actually when you look at the savings, most of it relates to public health. And it just made me wonder, you know, I know these budgets are quite complex, but it just made me wonder whether we were taking from one pot to another pot, and sorry, it sounds like a very blunt question, but is it a true saving, or is it just moving money around?
So I think that's a very valid point. I mean, in essence, we can't save on public health grant because it is a ring-fence grant. Because of the very challenging situation the council is in, unprecedented, the council has asked us to do some very forensic work to ensure that the public health grant is being spent in the best places to achieve public health outcomes, but also to support the wider preventative agenda of the council. So therefore, we've been looking at the investment we have in adult social care, we've been looking at the investment we have in children's services, housing and wider. We're having to make some pretty challenging decisions about things that we chose to do when we were in a much more buoyant situation, and are good to do things. But in the new world that we're rapidly facing, we're having to think about what are the more immediate and preventative work that we're going to need to invest in forward. That doesn't necessarily mean that all the work that we've identified, or all the areas we've identified as savings will cease. We're working very hard within public health and across the council to look at ways of mitigating those risks. So whether that's by bringing something back in-house into the strategic function that we previously commissioned, whether it's about redesigning services as they come up for re-procurement to basically bring together functions to get more economies and a better scale. Alongside that, we're also working with colleagues in other parts of the councils to see if there are some areas of our work that we could potentially get other sources of funding for. And if we're able to get other sources of funding, we'll be looking to do that. So all of that work will feed into the quality impact assessments that are in development at the moment for public health. And we'll be identifying whether or not we have a neutral impact, which we'll be hoping to do if we're able to redesign services, or indeed we'll be able to find other sources of funding, or if there's going to be a positive or negative impact. And all of that work will be shown.
really interesting, thank you.
I just make a build on that because one of the slight reading through this, there's not a lot about preventative medicine in here. And I know a lot of the work, I'm repeating what you said, a lot of the work that you do in public health is about preventative. So just to raise an alarm bell there in a way that actually you rob and Peter pays Paul sometimes, aren't you? So if we don't do the preventative work, are we going to suffer further down the line when in years to come the budgets are going to be even tighter? There's not an answer to that, I know, but it raised a concern when I was reading it.
And I think some of the challenge for us at the moment is also finding different ways of working. So over the past year, we've had quite an interesting work programme with our colleagues in adult social care, where we have been looking to train our social workers to be very aware of physical activity and the importance of movement in preventing frailty and falls. So we're moving to a place where everybody who has a care plan will have a movement plan, a sort of a physical activity plan as a part of that. And that's been really exciting to do with social workers, and social workers have really appreciate bringing that understanding of the impact that physical activity has on them personally into their own practice. Likewise, through safeguarding, we identified that cause of some fires across the Five Borough were related to smoking. So we've been working again with our social workers around identifying smoking, particularly where there is smoking and hoarding, and then what are the opportunities to put people in touch with stop smoking services, shifting people from smoking to vaping, managing hoarding to ensure that we have a really positive impact on health outcomes. And as you know, smoking costs social care a lot of money as well as the NHS. So a lot of what we're looking to do in public health is transformation. And where we are funding services in adult social care or in children's or housing or chief executive directorate or your it's always with a view of transformation. So if we're looking to disinvest in one area, what then are the opportunities to embed that practice in another part of the council and still get equivalent or better public health outcomes? So it's quite challenging public health work, but we're up for it, and the team is engaging across the council.
Sounds reassuring.
Actually, I think it's what Alan was saying is that those two projects we work in, is helping us to stay within the budget. There's a lot of the question in it, balance budgets next year rising demand. I think we are investing in prevention because that's the only way we can sustain, because otherwise we won't go do it. There's a lot of prevention initiatives there to stay within the budget, and public health funding is also helping us stay within the budget.
Also, I would say that Anna's done a really good job in kind of bringing together the whole public health grant across the whole council. Anna's established public health kind of board actually for grant funding. Before it was a bit bitty all around the place. Yeah. And this gives the board a kind of an overview across the whole council on terms of where money is going where, kind of from a centralised location, which I think has tremendously helped to try and get a better idea of where we are now or what's going where. And this has been some tough decisions made. There's been some kind of other parts of the council who have felt that we've had to give up some of their public health money to go somewhere else. But again, preventive measures that may have impact them personally. But I think we've kind of got on top of it now with this new kind of, as I said, Anna's introduced this initiative, which I think has actually worked better this year since it kind of started to kind of get a grip on where we are with this.
Galvanising that whole council.
Yeah, exactly. Yeah, exactly.
I was just going to ask a quick question on the NRS. And essentially, what lessons have we learned from their collapse, and how is provider credibility built into next year's risk planning?
I think for that, so that particular market has always been fragile. So not just NRS, but we had medical before it, of course. Got 24/7 healthcare now, providing equipment into people's homes. It's been really, it's been really tough. I must say, Gareth, who's not here this evening, has done a sterling job in trying to pull that all together, not just for us, but all the other boroughs that kind of rely on us to kind of go out of the contract. So we're always very aware that the market on the particular service that we commission, because the council itself can't provide healthcare, which are not allowed, so that's why we need to commission service as per the law. So that's one particular market that is failing for various reasons. One, the price was forced to be kept down for a lot of providers, so they couldn't make a profit, so they went under. With 24/7, of course, there's been some teething problems because they've not particularly had a contract this big before. But we're working through those now. There was problems at the start, and you had written, and I was getting so many casework with regards to that specifically as well. But it seems being ironed out. There are still issues, but I think it's better than it was maybe 2 or 3 weeks ago. But when we look across the whole sector, I think especially commissioning of services, we do take into account the best way we can on the market conditions at the time as well. But I think NRS was a particular, I guess, unusual issue because of the way it happened and how it happened. Benefit a way that it kind of happened slowly. So we kind of knew it was coming for at least a month or more. It wasn't just an overnight thing, which I know can sometimes happen. So I think the team is very, very aware of that and are working on that. Like I said, with the side issue, that obviously we can't access some of our systems. So people are having impacted by that, but obviously people are having to go snail mail or phone calls, back to the 80s to work. But obviously we're working through that at the moment as well. But there's a contingencies in place for that. And with NRS goals meeting now cyber incident, to ensure that we get the best results we possibly can.
We did talk through, we had a business continuity plan that progressed like any other contract collapse. Like I was saying, that we had enough time to organise the new contract. However, there are issues with the new provider which we are working on commission working on it. Not just for public KC, but other boroughs also facing issues with the delivery. I think the market was, as you know, is only 2 or 3 providers in the country. So not many companies were in that business, so we didn't have a choice to choose. 24/7 is a small company, so we're able to work with them. We're working with another company to support 24/7. So I think things we'll have to wait and see. Things will get improved. Things will improve. But we are learning lessons. We learn from that. We're adding those things in this business continuity plan as well.
It's just to say that commissioners receive alerts through credit check agencies such as the Fast Street that look at submissions of accounts and other financial matters. That are then alerted if there are significant changes in those from a month-to-month basis, and my team respond to any of those alerts and look at the financial information to give a view on sustainability as and when it crops up.
Thank you. Usha, I know you were going to ask me some funder fee, but I can answer.
You can go ahead.
I was just going to talk about the self-funder fee and just in terms of before this fee was introduced, understand the scale of the charge and what protections will be in place to ensure that it doesn't not create hardship or deter people from seeking and support they're entitled to. So I guess, and how will the self-funder administration fee be set and what protections exist for those?
This is something that we didn't want to do. I mean, but just given where we are, we had to find how we could support the overall council position to provide for people as much as we could. So it's not just us doing this, it's Westminster Council doing this as well, so we're in it together. It's a bi-borough service, so it's very apolitical. Obviously then so we did try to balance it up the best way we possibly could. And we also looked at other councils in London, and many other councils already do this. So we were kind of the outlier in that respect. So I've been really clear with kind of Gareth and the team kind of running this kind of consultation at the minute. We just launched about a week and a half ago. That closed on January the 9th, I think. To see what people think. So we've written to all service providers who have private arrangements to see what they think. So as it stands, the proposal is for people to pay £31 a week. It's a week, isn't it? Yeah, I didn't work. Yeah, it is a week. For the council to provide the support, and that's a really good deal. But also helps the council in terms of ensuring that people can have access to funding that can help other people as well at the same time. So we've done all that. I mean, I think as I asked last week, we had 0 responses to the consultation, despite us proactively going out to everyone we know that is on this arrangement for that particular position and see how they go. And I think as I said, it's quite minimal. Many other councils raise significantly more money than what we're proposing here, a lot more. But I think we're just having to try all options that we possibly can. But I think it's also it's 31. I know it's not easy for people to pay the bill, but it's £31. And you know they're having private arrangements. It's not like they were relying on the state necessarily. So we're just trying to work that through as best we can.
The idea is that we may be able to reduce the cost of care rather than an older person goes and speaks to an agency and pay more.
Yeah.
So in that way, they can benefit but their and also continue to monitor working with the agencies, not increasing more than what they're supposed to do. If it is in private arrangements, there is not much safeguards in place. So this is something we will be able to get a good deal for them. So that's that way. Those people will.
Yeah. That's good to
Yeah,
hear.
I think come across in our case where people get themselves in an awful mess through all of this. They're often at an age where they're quite frail, they don't, difficult to monitor all the
Yeah,
time.
there are some safeguarding issues. So they just, basically clearing up the savings or balances. So
And how do we publicise that? How do people get to know that through their GPs or what's the
yes, we will once the consultation completes. There'll be a plan to communicate that to our residents. And there is always a choice, and they can choose it very well.
Any other questions? If not, I'm going to
One last
last
question
question to Anne.
So somebody just said to me yesterday that people are concerned about. Everybody knows that budgets are tight and they're worried about the services. And this person said to other residents, said that there were where end users have direct payments.
Yeah.
Those payments were being reduced.
No, it does.
Is there any truth to that rumor?
I think that when you said direct payment is you do an assessment need and then you decide and we'll work with the resident to know how much they need to submit their care. And then we do a review to make sure that the person needs, if the person needs change, increase, then we put more money in the pot. If the person's needs, reduce, then we reduce it everything. But that's not written in stone. That is based on the person's.
always been like that, though.
Continue to, if the resident concern, they can write to us and we will do another review and looking at the budget, etc. But we will make sure that the person's needs is improved. So if there is a shortage, if there's no money, enough money to buy the care, then we'll have to,
Have more in. I just thought it was an interesting thing to hear, and I just wondered whether we might hear more of this from residents who feel more the pot's getting smaller and therefore I'm getting less. And
and it's really good point because actually I had a meeting with ADKC, Action Disability Kids in Chelsea, for those who may be very similar issue. Some of their service users were querying that basically, but it wasn't. They're not reducing. It's just how their care has changed.
Yeah.
And as this says, it's updated all the time on the basis of their need. So it can go up, it can go down, depending on where.
And we're not changing our criteria.
Well,
No,
that's the next question.
no, absolutely not. No, that's right.
Right,
There's
that's the next
no
question. Like, oh, you need 4 visits this week, but actually now we've decided.
No, it's nothing like that at all. No, that's right.
those assessment of needs done by qualified social workers or trained social care professionals working in partnership with the resident. And also, before you decide how much care they need, and the social worker may speak to the GP, district nurses, and various other people. So I would reassure that if there are residents who feel that their needs are not fully met and they haven't got enough money to buy care, then we would like to know, and we're very happy to do a review or assessment, etc.
I mean, there are certain rules around as well, so people can't just go out and buy a brand new cut or something, which some of the questions we had, some of the questions we've had is like, well, why can't I spend money that on a, you know, a hot, you know,
Sure.
a first class trip something, or whereas it's like, well, we can't because you can spend it on a certain way, but you know, it's up to you. So we have some of those questions sometimes. But yeah, that's very Andy, when it comes to
So as part of our wider prevention agenda with adult social care, we're also working with our social work teams to make them more aware of the voluntary sector offer. And sometimes the need might be around connectivity in the community, or befriending, or there might be. We work very much with strengths-based practice, so we very much ask clients what it is that improves the quality of their life, what are the things they like to do and that they're good at. And what we're trying to do a lot more with social work is to get them to think much broader beyond the traditional care package, and to connect them up with the community organisations that we have within our patch that can help develop those interests and those skills and bring them out into the community. And again, that's been another really exciting piece of work to watch grow and develop over the course of the year, and the feedback from the social work teams has been that it's really promising.
Very good, yeah.
I guess it's a worry now with the whole funding of the PCS and also needs to be pressure from directions. I think it's really helpful, because I think that is something that we as councillors will get from our residents. Oh, the pot's getting smaller, so therefore what I get is smaller. And I think it's helpful to know that they can, you know,
their criteria.
this and your team, and that can be answered for them. Because I suppose people do, you know, that is what people do. There's less for everyone. Thank you, it's really helpful.
Mary.
Yeah, apologies if I've missed any of this, because in the cheap seats, the acoustics aren't great.
Coming to business class.
I'm a bit perplexed about how these cuts are set out, because basically 40% of the savings in year one are redirected public health cuts, 80% in year two, and well, a mere 11% in year three. And they get very little explanation, and they get no risk assessment at the end. So you don't get a line for each of these. You have a little list of them here without any proper analysis of the impact for year one, and no explanation about what the cuts are in years 2 and 3 in public health. And yet you put figures in for them, at least as far as I understand it. And I don't think that's a reasonable way to present the budget cuts, because you're missing out on half of them. And there's no way that we can comment on them or have a view on the risk that they pose. I mean, Gerard raised the question of prevention. You know, the public health budget is all about prevention, and yet there are some very big cuts proposed. And there's no narrative. And I don't understand why, because this is the public health and adult social care budget. You don't just have to explain the adult social care budget. So why is that?
So our ring-fence public health grant, as you know, is exclusively for a prevention activity. And we've always worked across the council to kind of galvanise a whole council approach to public health. And we've always invested in all the directorates across the council with the aim of developing the preventative potential of the different arms of the council. So given the funding cuts that the council is facing, the council have asked us to do a real forensic analysis of where money is invested across the council, and to consider whether there are initiatives or programmes that we would look to re-divert money to other parts of the council where we could get equivalent or better public health outcomes. So we've been working very hard through that process over the last few months with our colleagues across the council. So as Councillor Rendell said, we've got a public health board. At that public health board, we sort of have a vision for a sort of shared priorities across all the different directorates, which has informed our funding to date. The conversation we're now having with directorates is in a less well-funded world where the council is facing cuts of 88 million. What preventative services would we look to either stop doing, to reduce, Or is there some transformational work that we could do across the council to bring functions or services together? So one example of that would be we recently recommissioned a children's substance misuse service, but it's not just the substance misuse service now. We've built in an aspect of sexual health into that service to impact on sexual health prevention and people coming through front door of sexual health services. We've also looked at the mental health offer within that service. And we've kind of developed it as a wider risky behaviour service because children and young people don't experience things in silos. There's often a mental health aspect, or substance misuse can come with sexual health, risky behaviours, etc. So that gives us an opportunity then to look at our sexual health budget and see is there opportunities then to constrain the budget there, particularly the demand-led services, because we're modelling that we'll have some impact with that new service that serves people aged 9 to 25 years. So that's the kind of work we're doing across the team to realise these savings. I think none of these are easy decisions because a lot of what's listed here, it's really, really positive work. But some of the conversations we're having, for example, with our colleagues in E&N is for some aspects of work, could income generation be used to fund those projects or initiatives moving forward? And then could we then divert the public health money into an aspect of adult social care or children's services or housing where there is a prevention opportunity, but we haven't to date exploited that prevention opportunity. And in doing that, we'd also be looking to work, like we've been working with colleagues in adult social care, to see if we could train frontline housing workers, or are we really maximising on the work we're doing in our family hubs and to ensure that we're achieving wider public health outcomes for children. So it's a journey. It is really challenging public health work, but we're facing really difficult times and we're going to be working with much less money. And if there are opportunities to exploit council services to work in a more preventative way and deliver public health outcomes,
I appreciate that, but none of that explains why you have not presented that properly in this budget. You know, you're talking about serious cuts without a lot, you know, you're treating public health cuts as less important and less deserving of explanation and a line each in a budget than you are adult social care. And yet you're, you know, you're managing to reach your adult social care sort of and public health targets by a huge cut, which only gets essentially one line in public health. And I don't, you know, that's not, scrutiny needs more than that to do its job properly.
Yeah, I think that
I can't see why you'd have done it like that.
No,
I
we
don't
are
understand.
we are going to do an EQIA on all those projects.
But not bring them to the
not
open
yet,
scrutiny
not
committee.
yet. We will be doing the DQIA.
Exactly.
We'll be doing the DQIA on all those projects we put forward. But another point is that, you know, we can't find direct savings from grant. It's a public grant, isn't it? So that we have to spend all the money, but it will be savings from the revenue.
Nobody's questioning any of that.
Mhm.
This is the
More
approach
detail.
you've taken, and I'm sure it's a good one, and that all that you've said is perfectly reasonable way to tackle a big problem like this. What is not reasonable is not to describe those changes properly in a report to this committee.
We take your, I think we take your point, and also we will include those full details in the EQIA.
And I
The
will,
next
that.
iteration of this paper.
yeah, I will also say there is an element of this where your note in the tables, we talked a little bit more about the core elements of the public health funds that we'll be reducing from those public health services. The aspects which are in other directorates across the council, so for example, some of the physical activity interventions, some of the housing and employment, etc., they will be picked up in those councils' budget scrutiny and saving sessions, because those interventions are a part of a wider portfolio of work within those directorates. So we've dealt more discreetly here with the core public health ones, knowing that they're the other savings across the council need to be a part of the savings in those
That's a
directorates.
discussion that we need to have, because public health as a concept does fall under this committee.
Mhm.
And although we may well have reallocated some of the money towards supporting other directorates, the whole picture of our public health effort needs to be scrutinised by this committee, whether or not it's
Yeah,
actually
I-
being spent in other
I
directorates.
think, Mary, just in the defence of the team, and I'm not defending the report, and I would completely agree with you on that, the public health board only met one day before this report had to be out. So they only agreed the savings on that day before this had to be published. So just given that context as well, that they only met on the Friday and this had to go up, whatever it was. So it was very, times of the essence
I
of
think
that.
it comes down to
No, no, but
prioritising.
that's how these things, just how, it's just. how
I
these
assure
things
you
But
lots of
maybe
work
next
is
year it needs to be
taking
planned
place.
differently with an eye on scrutiny.
Yeah.
And getting different. If I just make one other observation,
Yeah.
and you picked it up in your narrative, and that is the lack of emphasis on transformation in this budget paper. And we talk a lot all over the council about transformation, and I'm sure you just described some great work that you're doing.
Mhm.
But it's really important that these papers to scrutiny reflect some of that work, even if it's only a few vignettes of good work being done. Because it's really important that the rate-paying, council tax-paying public understand that we are making imaginative efforts to do things, and also good practice needs to spread throughout the council. So I just urge you, in that case, just to blow your own trumpet a bit more.
Thank you, yeah, we will do.
And we can look to share some of those, and we've also got some little videos of people in the community.
I'm not suggesting that the paper should be twice as long, but just a few lines describing.
There's some stuff we can circulate around case studies to the committee, and we'll do that.
That'd be great, and also to the working group.
I was going to say,
on
with
transformation.
Mary's record, is this the same paper that is going to the working group that we can maybe include some of Mary's recommendations and how it's presented?
Yeah, we can do that.
What was going to the working group, just in case colleagues don't know, there's a standing working group for the Overview and Scrutiny Committee, and a representative from each committee will go with the key findings and themes from each of the 4 select committee meetings. So the working group is looking at themes across, and I think what's coming across in the meetings so far, based on Mary's last point, is about the budget papers maybe need more information about transformations, not just this committee.
Just pretty many questions. I'm just going to take.
I'm fine,
Thank you, Jared.
Just really building on that, and just for us as a committee, looking at how are we going to increase our monitoring of this whole budget process, and maybe it's something we need to feed in, because I think it slightly gets lost in various, the leadership team do their review of the quarterly outturn. I don't know how much you do on budgets on overviews, but if this is going to become more of an issue and we need to give more focus to it during the year, how do we build that into our meetings? And because again, just to reinforce, this paper doesn't give me examples really of where this is what's going to be hit, where the savings going to be made, what's the impact going to be. And I think we're just going to have to get our act together more during the year if the pressure is going to be on it. And I'm not quite sure whether that sits with us, it sits with Overview and Scrutiny, it sits with who it does.
Jackie, I don't know if you want to make a quick contribution on that point.
The Overview and Scrutiny Committee looks at the quarterly financial monitoring reports, and that's for each directorate. And in the recent peer review, that was something that the LGA said Scrutiny should be doing. That was a good point. So those reports are in the Overview and Scrutiny agendas. So if it's helpful to the committee, I can let you have the link to that report, but also if you want any information from that, Lucy, of course, is on the committee and can also bring information back here. But I think that any reports that you get to this committee during the year may include budget information or KPI information to help you in your scrutiny of the topics as well.
And real live examples.
Yes.
Pretty.
And just very quickly on everything that's been said, it'd be very nice, even, and I'm sure you might have it somewhere, to have some data with all the wonderful services that you offer across the board. What is the return on investment? How often, what's the efficiency of the whole package? Is it being utilized properly? Is there enough, enough uptake? Is it worth funding that service if it's not being used. So that sort of data breakdown, which can help into, the transformation process as well.
And I assure you, particularly in public health, that's very much a focus of what we do. I'm really pleased to say that we do excellent public health services. We work really hard to look at things like return on investment, looking at outcomes, understanding the number needed to treat with our services, and are we getting the right reach for our services? So who's coming forward and accessing our services? And that's something we're continually working on.
Use of contract insurance.
Yeah.
Just wanted to add to that, OH is also doing a deep dive and they're going to scrutinize all the public health funding as well. So we are involved in that process. So it helps. Yeah.
So quality is very much. Yeah.
Thank you very much. I think the main recommendation here is marries, which is the next iteration of these papers, just to have more information of the health. Thank you everyone for contributions. Moving on to agenda item 5, which is the adult social care and health performance report. This report provides an update on adult social care and health directive performance indicators related to the service quality. Same, yeah, pretty much.
So, as you can see, there is a list of performance indicators there, and then some of them are statutory returns, which we have to report to the World Safety Department of Health and Social Care. Some of them we have chosen as a good practice to make sure that that we know how well our services are doing and how well the residents are satisfied, etc. So those are the things. Some of them are statutory, some of them are not statutory, but we think it's good to do that based on best practice followed by different councils in the country, which was again endorsed and amended by the CQC when they came to see us. For example, there was a performance indicators on the reviews, which we don't have to report to the Department of Health, but we want to know what percentage of people we go back, like for example, the point Joseph Panel, that about the direct payments reviews, etc. So we must see them once a year, which we know that we do it quite well. We go back and check with them whether the care package is working or not, etc. And so far, apart from direct payments, I think we're doing quite well and meeting all the targets what we set on other performance indicators. The direct payments, still we are one of the best performers in London. I think it's second highest, apart from Enfield. But we are ambitious and we want to do more, which is that's why we set the target for 40%. And this is 1 to 2. We are going to try to hit the target. So there's a lot of work taking place to make sure that in end of the year we will be able to meet the target, and we are confident that we can meet the target. So I'm happy to take any questions. I mean, these performance indicators are, some of them, public health, some of them adult social care, some of them statutory, some of them are chosen by us to make sure we think is a good performance indicators.
Thank you very much. Who would you like to start?
Okay. Thank you, Sharon. I was just curious to know what are the risks and consequences of redirecting the 3.1 million from children health and community wellbeing and inequalities.
Which pages are?
The risks and consequences of redirecting 3.1 million. On paper 5.
Oh, is that package?
Is it
In the previous?
Apologies.
So
And what I would like to know as well, you spoke about the performance indicator. How will that be maintained and improved during a period of financial constraint?
I think the performance indicators are very important, especially during the time of financial constraints, because that, Tom was talking earlier, to set the budget also we need to know how many reviews we're doing, how many assessments we're doing, how many referrals we're getting, if there is any trend that is going up or down. So the performance indicators are very important. So we set up all these like framework, like every month we have this performance meeting. The performance meeting attended by the finance colleagues. Likewise, we have a finance meeting attended by the performance colleagues. So they work together and also data cleansing, etc. So most of the performance data used by the finance team forecast on the spend, and also, for example, that we asked for the 1.5 million growth, which is based on the performance of the number of referrals, etc. So it is very important to know about our performance so that we can make sure that we have the right budget for those needs of those residents.
Is there, just leading on from that question, is there any particular area that you're worried about sustaining in the next year with pressures that we're currently facing?
I think there is it's not because of the money, but it's because of the taking of the direct payments for various reasons. So that's why we are worried that we haven't met the 40% target, but we're working towards it. In terms of impact, the budget side is that if we don't have enough staff, we won't be able to do the reviews.
Yeah.
So we set a target, normally it's about the country is about, so although it's not a national performance indicator, but what we know from the local data in London, it's about 67% all other boroughs are doing, and we're doing about nearly 90%. So even if we don't do 10%, we're still doing quite well. And I think that, yes, we have identified some savings in staffing, but I think with the systems we put in place, we will be able to meet those targets on the reviews again.
So you're not, basically, you're saying you're not.
I think I'm confident that we'll meet the target on the reviews. But again, point is that Councillor Hargraves was talking earlier about the demand-led budget. So, for example, if there is a significant increase in referrals from hospitals, then of course we need to divert all our resources to do the assessments rather than doing reviews. But as it is now, we will be able to meet all those targets.
Yeah. Portia, sorry, I jumped in on.
No, it's fine.
You've got another question.
Yeah, come again.
Thank you, Jeff. To start, I found this quite difficult to read because some of those percentages are going up and some are going down. Yeah. And when you think, oh, that looks good, actually, or the other way around, so it's not easy to read.
Yes.
So some of those are statutory targets, and some of them we set ourselves.
Yeah.
If I was being cynical, which of course I'm not being, when you see a whole page of green with just one number, you start thinking, okay, now I'm not thinking that at all. So, beg your pardon. So how, the ones that we set ourselves, where do we get those figures from? And some of those, if you look at year end 24-25, then target 25, some of those have changed. And some of them, if I'm right, seem to have downgraded the targets a little bit on some of them. Others have put them up. Help me.
So I would say, and I will talk about the public health the targets, but in the adult social care, if you look at the first one, percentage of people leaving rehabilitation without the long-term package of care. This is basically about people, the type of reablement we provide those people discharged from hospitals. The 6 weeks reablement, they get it, and they no longer require any long-term care package. So that means that effective reablement we provide, therefore they no longer requires an ongoing care package. But that you will see there is a last two columns, London and England. So the London target was 77.6 and England was 79.4. So we set a target of 80%. So that is higher than the England target because London is 77%. And then we'll see the first column, year end 24-25, 87.6. And you asked the right question where, but the target was 80%, but we year end was.
So why did we get 80% from and not 81 or?
Because we want to be more than England target of 79.4. We want to be top. That's what we are outstanding on Wilson. And so we set the target more than England.
But I'm wondering, it's like, why 80 and not 8? What thinking behind it? Why you said why you set it at 80?
I think because 80 is a very stretching target.
Okay.
We thought that's a reasonable sort of a, you know,
half scientific and half.
Yeah. There's no scientific, you know, there's no sort of mathematics there that you have to be done. But what we always look at is the London and the target. And we try some of them, like for example, direct payments is always a challenge. And so we said that we know that Enfield is higher than us, and I think it's 44%. We know that we need to do more on the direct payment, but that's what we're working towards.
Is there any reason why that 40% is 40%? It just feels like quite a low percentage.
I think is if you look at the England achieved only 25.5 because people, it's a lot of work to do. This direct payments is not for everyone.
Yeah.
If people with mental health problems or people with learning disabilities, if they don't have a carer who is able to manage opening up a bank account, employing, interviewing, employing a carer, they need to have some time and energy to do that. So it's not for everyone, but it's the best way to provide care because it's empowerment and choice, isn't it? That they can recruit their own carers they want to meet the person's needs. But if they come to a normal route of hiring carers through an agency, they wouldn't have much choice. So it's a lot of choice and control, but it's not for everyone, and it depends on different boroughs. Yeah, if you have a family member or families there come together and able to do it, they can do it. If someone lives alone and can't do it, they can't do it.
Do you want to finish?
Just 0.7. Can you?
Let me talk about NHS health checks because it is usually confusing. So NHS health checks is a 5-year screening program. So when we're evaluating it on an annual basis, we're working towards a set of targets that accumulate across the course of 5 years. It is one of our prescribed public health services, which means that the direction centrally is incredibly clear in terms of what an NHS health check is, what happens at each appointment, and how it is measured and how it is evaluated. Now, that 20% target figure looks very low because essentially when you've got a 5-year screening programme, each year you're calling up 20% of the population. So we need to ensure that we're calling up 20% of the population each year. So in 5 years' time, we've offered the NHS health check to everyone who is eligible for that NHS health check. We measure 2 aspects of it. We measure what is offered and we also measure the uptake And I'm really pleased to say that if you look over the 5-year period, 75% of those who were eligible received a health check. And that's significantly better than the London average of 41% and the England average of 30%. And we're in the top 10 local authorities in England for our NHS health checks. But when we have to break down targets over the course of a year to feed into how they are technically measured, it's really important that we're putting forward our prescribed public health services, and something like health checks, where every aspect of it is aimed at preventing premature mortality, which is what we're in the business of doing within public health. Finding a way to do that that's meaningful will be quite hard, but that 20%, meeting that every year is important over the course of the 5 years, and 75% people receiving a health check across the course of 5 years is outstanding.
The figures don't convey any of that really, do they?
No, they don't. No. And that's something that I recognise we could have put more in the text, and we'll look to do that more moving forward. It's not a dissimilar situation when you look at substance misuse figures, where on the surface those figures look low, and you could be forgiven for thinking that 30% of non-opiate clients completing drug treatment who do not represent might not be considered good. Actually, it's exceptionally good for an inner London borough. So our comparison there is against an England average. But we, in an inner London borough, would have a higher percentage of crack cocaine users, which is one of the groups we're looking at within this setting here. We also have a higher percentage of those presenting with dual diagnosis. So the complexity of our clients is really tricky. And again, what we come back to around our substance misuse services is the number needed to treat. So the number that we need to treat or have passing through our services to have a successful outcome is considerably higher than the 30% you see here. Every time somebody goes through treatment, they build up recovery capital. So people might not quit the first time, second time, the third time, but by the time we're getting to time 4, 5, and 6, we are seeing more significant impacts. And our substance misuse services are really outstanding. We're really pleased about that. We benefit from being in central London, having a lot of the national experts locally, and some of the really clear examples of national good practice, like for example the Club Drug Clinic in Earls Court, that does a lot of work around, again, our particular cohort that would be slightly different to an English average, where we might have a lot of people experiencing the nightlife. Chemsex as a part of that is a significant challenge as well. And again, that would all feed into these non-opiate clients. For our opiate clients and for our alcohol, again, our uptake is above the average. Or our impact.
No, that's really interesting. That's really interesting. It wasn't so much that, it was just the fluctuation in those figures going across the board. Because if you look on the opiates one, the figures are sort of consistent, aren't they, right across. And so anyway, I've made my point.
I was just curious. I wanted to know how will the workforce redesign maintain statutory social work capacity to support staff in this change?
I think that we continue things that we call it learning and development lead, and continue to work with social workers in training on strength-based and various things, including safeguarding and other things. The one thing I always say is that one could be to continue to invest in learning. That's why our retention figures are very good. I'm working with the universities, working on various research projects, contributing to research projects, etc. Where learning and development lead has a Jane Royce, and now she's working with Anna's team as well. She's excellent. She's fantastic, and she left RBKC and they brought her back. She's really top class. And she has been working with the universities, bringing them on board, and continue to develop our
How many
social work.
social workers have we got?
We've got about 112, and they are, most of them are permanent.
This is why I asked the question, as in how are you gonna maintain the statutory social work capacity?
Yeah, I mean, I would say, but I think the last count was about 10 agency staff, not all of them are social workers. One of the directorate has the higher low number of agency staff. And we have some staff based here for a long time. And we continue to do well on retention. That is again recognized in the CQC report. And we continue to protect frontline staff in the savings. And you will see there is a saving proposals on converting social workers into care navigators. They're not permanent. There are vacancies and we want to do them. We think that's the right thing to do. Because of the care navigation also needed, not just a and that's something we will continue to work on along, continue to develop our workforce to be resilient and able to cope with the changes in terms of legislative changes or financial changes, etc. So that's why investing more in strength-based practice, which is something nationally recognised by Social Work England and also ADAS, etc., working to make our social workers more resilient, coping with the challenges they face.
I was just going to ask a couple of questions. Just one firstly on data quality checks, which you state in 5.14. That you're undertaking regularly, and to understand how robust our data quality checks are.
We have a data quality team, and actually he's here. It makes it quality. I think that his team is fantastic. I mean, I was speaking to him 2 weeks ago. I was checking on this report. So he produces everything we want, all the data. And that again helps finance team. So data quality is that you have a data and also the quality checks and the validity of the data they do. And they work with, we have a quality assurance team. They collect a lot of information, talking to providers, talking to safeguarding victims. We do something for making safeguarding personal. So if someone had a safeguarding incident, so those just go back to them and say how they felt. So it's not just numbers in terms of data quality data, it's also qualitative and quantitative data. And then they produce reports for the performance board, which meets once a month. Next team. And also they work with a corporate performance team with the RBKP. And that data contribute to the council plan. And they also work with commissioning teams, social work teams, gather a lot of information and provide so many reports for the senior management team within the adult social care and public health, and also for the council corporate.
I think Nick is the unsung hero, Chair.
Yes.
As you can see, he's over there. But I think holds the team together. But I was just backing up what this says really. But it's I think we're excellent at that. Really outstanding stuff. From what I've seen personally as well.
Yeah, and working with all the, not just adult social care, he works with all the departments within the councils not just in performance, but it's like the earlier questions about performance is important for finance. We want to know how well we're doing, how many referrals, etc.
Yeah.
So if I need anything, I'll go to him. And also, governance as well.
Very reassuring. My last question was just, obviously there's strong overall performance, but do we track variation by area, ethnicity, disability, or kind of any other characteristics? In order to be able to understand whether some groups are experiencing better or worse outcomes than others.
I think will be, but just in adult social care, yes, EQIAs we do. In terms of safeguarding, we're doing really well. And you had a report.
Yeah.
We're doing fantastic on the AME referrals. The Sunbar has done the referrals, don't get enough referrals. So we're doing really good. Service provision to the AME groups are very good here. Not just assessment, but also receiving care. And we are making every effort to provide culturally sensitive service, sensory impairment, correct service. We have some very dedicated people, very highly trained. The fact that lead person one of the staff have always column, and then so we've got a good services, I think, and that is again councillor that was recognised in the EQC report.
Thank you. Mary, any questions?
I was just going to observe that I'm sure these that there aren't very many KPIs here, and we used to look at stuff. These are the corporate KPIs, and I just wonder if we ought to be a bit more granular in our approach, or more detailed. Sorry, not granular. And that we used to look at stuff like how many days it takes to get somebody out of hospital, and so on a regular basis, and look at the trends on that, all of which affects the overall picture. And I just wondered if there was a case for in future reports having a bit more detail and over the contract monitoring. And I'm really pleased to see contract monitoring in this report because it's incredibly important and it's so much the money that we spend. There's no sense of the overall health of any of these contracts, and it may be that they're all fantastically performing, which again is great, but individual home care providers, are they all performing as well? And are there any red flags? This just picks up some, this picks up some very important performance indicators, but I'm not sure that it's maybe giving us the whole picture. This is a work in progress, doing KPIs, so I'm not suggesting anyone's done anything wrong. It's maybe.
And I can give some examples. So if I think particularly about health visiting, so health visiting have been an area that was a challenge for us. We've got 5 mandated checks in health visiting that we need to ensure are carried out for each patient. So they're things like the new birth visits, and then there are various checks right up until kind of readiness to school. We identified fairly early on when we relet our health visiting contract that those 5 mandated checks were not being met. So we went through a contract monitoring process with the organisation. So we issued an informal improvement notice, we issued a formal improvement notice, and then a part of that formal improvement notice, we then had a very direct plan with the organisation where we literally sat down with them, we worked out you need X number of health visitors doing X number of hours, seeing X number of mums and fathers and families to get those checks through. So we really worked hard to ensure that we had the right number of staff doing the checks. And we also looked at when we were offering the checks, and we realised that some of the default was due to when people returning to work, getting to clinics in the daytime during the week was tricky. So we piloted some things like Saturday clinics to give a greater offer to families. I'm really pleased to say that we are now green across all our health visiting indicators.
That's really good.
It was a process that we needed to work through, but any contract that is failing to deliver, we work through that process. So we're very conscious, A, it's public health money, but B, it's money given to us for a specific purpose to get specific outcomes. And it's our responsibility to make sure that happens.
I suppose I'm partly making this observation from a procurement aspect, in that we haven't been very good in the past at monitoring contracts, nor at levying the fines that are at our disposal within the contract terms when people fail to fulfil. And this doesn't give us a sense. I mean, the committee not here to monitor in detail everything, but just to have a snapshot every now and then about those
He was under
things is
instruction
really helpful.
plan, he was that sort of thing.
Thank you. I was going to say to Benedict.
Can I just one comment on the very good questions, Councillor, you asked about the delayed discharges. We had the performance indicator last 2 years ago, wasn't it? It was last year. Last year, then it was dropped by the government. So that means it was a very good one, but for some reasons it was a statutory performance.
And do we still record it even though they've dropped
we
it?
can, but it needs to work. The health also need to work with us because they need to tell us, you know, the definition of date of admissions, and also tell us date of the
So
ready for
it's become harder
discharge.
to capture because it's no longer
Yeah, they use
statutory.
the different terms, isn't it? Ready for discharge. Then they changed it to medically fit for discharge. But all these stopped. But it was a very good performance indicator. But sadly, it was dropped. But we can find something relevant to
proxy.
that. Yeah,
That would be great.
happy to do it.
Pretty.
Thank you, Chair. Very quickly, your point, the point 3, the direct payment update. Why, what would be the reason? This is my curiosity. What would be the reason for people not to take up the fame within the criteria, or what is the reason that most people take it up?
So some of the qualified direct payments is like same as someone's entitled for a home care through an agency. So there's no difference in criteria. But what is different in people's circumstances? Because if you want to receive direct payments, you need to. It's a lot of some work to do. Like you need to open a bank
Yes,
account.
private wallet.
Yeah.
Yes,
and
and
also
exactly the system.
need to do all these a lot. So some people don't prefer, and also, it's like I said, it's a good tool to promote choice and empowerment, but it's not for every service users. For example, an elderly person lives alone.
Sure.
She or he can't manage the process. So that is why in some boroughs they're not doing quite well. It depends on the makeup of the community of residents and the families. If it's a single household, then it's
And do we have a figure where private payment is taken up, the savings that we as a borough, instead of having, not having the private payment? Do we have
direct
the-
payments.
Yeah, direct payment, sorry.
The direct payments cost less for the councils.
Yes, exactly. So that's what I'm saying.
Yes.
So do we have,
Yeah, we have.
what percentage of,
I would say that probably if you talk about a care package, we call it care package. I would say we can save at least 10-15%.
okay, so that's quite,
yeah.
that's quite considerable.
That's true. But we cannot force people to take that.
No, of
We
course,
have to
sure.
work with people to do that.
Mhm.
And we have introduced various, but I'll give you an example. We thought we set up a new team, dedicated care direct payments team, which has helped to increase in hand-holding people to go through the process.
Right.
And that increase, and I must say again, I think we are the second best in London, so we're doing quite well on direct payments. But we want to be ambitious, we want to do more.
And so that's worth investment on having a team.
Yeah.
And just finally, across the board, how many agency staff do we have compared to your original point of having a more permanent social workers?
Yeah, it's about,
But across the, what's the spread?
yeah, I mean, it's changed at the same time, but I would say roughly about sort of 9 to 10, 12.
In percentage terms.
I would say,
What is the staff? What
but it's
percentage?
agency, not all those 12 agency staff are social workers. They could be.
No, across, I mean, just
I
general.
would say maybe, I think, I can't give you an exact figure. I would say maybe,
Would you say 10% of the staff
10%
is
not
agency?
10%, 4 to 5%.
Is agency?
Yeah.
Agency staff,
Yeah.
okay, thank you. Thank you, Chair,
So, yeah, 3 to 4% is very low.
thank you.
I think that is a very good recommendation to make for next year. But I think that brings us to a close on those. Thank you so much, because I appreciate what a difficult year it is, and it's an incredible job you do in balancing our budgets, particularly in AFC, which may be one of the most stressful things we're working on.
Thanks, Jack.
And thank you everyone for spending your evening. Moving on to agenda item 6, which is the work programme report. This is an update to the work programme. The municipal year 2025-2026. Did any member have, we went through this the other day, but does any member of the select committee have a point to raise on this item, or are we complete with this report as read?
Chair, happy with this, but just to reinforce the point that do we need to be doing a bit more monitoring of budgets and a bit more reporting
Yeah.
going through the year?
Definitely. And I think we had decided to, what did we decide in the last meeting, that we were
So-
going to do a
Yeah, so I think the resolution in the last meeting was we would get the facts about how the new local government task was funded, and then provide you with facts those that you from there.
which will be on.
That's the one I'll start with. I'm talking about also during the year.
I mean, if you're talking about the rest of going forward in the next 6 to 12 months, I think that's a discussion we'll want to have with maybe the integration agency and coordinate with them.
Because
So
that's,
I'd like that to come back for a discussion here so that we are satisfied that the adult social care and health is getting enough attention going through the year in what's going to be a really difficult year. And I don't know where that specific adult social care and health is with diversity, it's with Mary, or is Mary more general? Do we need to do a bit? I don't know.
I think we discussed, if it is a case of bringing it forward, it would probably need to go, something would need to be moved from February to March, and it would go in February.
Yeah, so we did talk about the idea of possibly having a paper in March, because that's when there is capacity, if there is sufficient time to do that. If you're thinking of something more,
We're talking about two slightly different things. We're talking about a paper that focuses on the reaction to the settlement. I'm talking about, in addition, the monitoring through the year.
Mhm.
Because we heard today that there's going to be some really challenges throughout the year. Where does more focus on adult social care and health happen? Does it happen here? Does it happen in overview? And I don't know the answer to that. But I mean, clearly, we're going to need to do more than we've done in the past because
Yeah,
the challenge is going
yeah.
to get stricter.
Yeah.
Yeah.
I think that's a good point. I think the budget will be an increasing area of focus for scrutiny going forward, as we've heard tonight, severity of the situation, what council is facing. And I think the place of that discussion is when we come to look at work programming, what committees will be doing in the future as well, and joining up with OSC and how, what they look at and when in the next 6 to 12 months.
Becky, do you want?
I was just going to say, if it's helpful, I'm not suggesting you haven't seen this report, you may have done. If it's helpful, I can circulate the most recent report to overview, the quarterly financial report. You can have a look at that. So that's looked at that committee, and that might help move the page on. We can see what there is. But when overview looks at that report, Lucy might see something in it at that meeting and say, this really needs looking at, I'll bring it back to my committee. So there's that process as well.
Because we'll be having quarterly updates on, yeah.
Yeah, so, yeah.
Does that sound?
Yes.
I mean, well, I think maybe what we could do as well is it could be something that the committee recommends is taken forward into the new municipal year.
I think we did look at the additional pressures that could face residents in this situation. bring it to the workshop so you can look at it every 3 months, over 6 months if possible.
Bring it to the workshop. You mean the
The work programme.
Because it is gonna face a
Yeah.
year pressures,
Yeah.
so
The only
that
thing I'd
it
say with
doesn't
that
affect
is-
residents, you look at it.
we're
3
not going to
months or
see
6 months.
those effects until after those cuts, and the work group we're talking about is only meeting in December and January, so that would
December and January.
as in the budget group.
The budget working
Which I think
group
you're
meets in
talking about.
December and January to look at this draft budget. Were you talking about the workshop that for scrutiny councillors to plan the work programme ahead, the year ahead?
Yeah, okay.
Definitely,
Yeah.
take it there. Yeah,
That's a good idea.
good idea.
Any other comments? That concludes the meeting of the committee. Thank you everyone for your time and attendance this evening.
Thank you.